Hi, this is Junaid back with another lecture. We're going to talk about in-hospital management of acute ischemic stroke, treatment of acute complications. This is in continuation from the last lecture in which we discussed the general supportive care, and now we're on the section 5 of them. The two big complications that we are worried about is number 1, brain swelling, and number 2, seizures. Brain swelling is definitely much more complicated. Patients who have a large territorial stroke with left MCA, large right MCA strokes, and are at high risk of developing brain swelling. And those especially with subcortical area involvement, ganglionic involvement, that is right around the area of the ventricle, and when it starts to swell on day 3, they are actually at the highest risk of producing two effects. Number 1, of course, brain swelling that can cause herniation if untreated. And 2, they can actually compress other arteries and increase the different strokes in different parts of the brain. Let's say if there's a large left MCA stroke and the patient continues to swell, the ACA can get compressed or PCA can get compressed, and they can actually eventually have more strokes burden because of that complication. In both these situations, it is important that shared decision making is made. The neurointensivist, the stroke physician, the plus minus neurosurgeon at that point in time need to make a decision of how to proceed, if just medically, or have a plan if it's medical and surgical or medical only. And depending on the patient's preference, patient's wishes, some patients have basically decided that, hey, we're going to monitor for X amount of hours and we see what the improvement and or worsening is, repeat CAT scan shows, and then we're going to go ahead and do the surgical resection of the scalp. And if you're not going to do that, technically speaking, we just do only medical treatment. It depends on the patient's preferences and wishes as well. Some families say that, okay, if we get up to a neurosurgical option, then we don't want to take that. At the end of the day, it is very, very, very important to let them know that this is a life-saving procedure. It will not improve their functional outcome, and some families do struggle with that point. So I have to make it very clear to maximum amount of family members that we're not doing this, that we're going to do the surgery and the patient is going to miraculously improve. That is not the case. We're just taking care, opening up the skull to make sure that the patient's brain swelling does not affect other parts of the brain, or basically making sure that the patient is not going to die from it. So those are the two things that were very important. And given that situation, I think the best place for that patient is to be taken care into a comprehensive stroke center in a neurointensive care unit. And those are the patients that should be transferred if need be. Again, there's no real evidence-based medicine behind it, and can't be. I mean, nobody's going to sit there and study that. So the class of recommendation is 1, but the level of evidence, as you can see, is C. As far as the medical management goes, clearly use osmotic therapy, and there can be a big lecture on it. If you want me to, I'm happy to do that. Please leave that in the comments. But at the end of the day, hypernatremia or hyperosmotic therapies of different kinds, including mannitol, can be used to decrease the burden of swelling in the brain, and they do work. Clearly, I've seen some patients we have saved from getting surgeries in those patients. However, when you're using that, there should be a clear guidance that is just medical only, and God forbid at a certain level we're going to withdraw care, or it's going to be medical plus surgical, and therefore the plan needs to be established before we even institute these therapies. That avoids confusion moving forward. Hyperventilation therapy should be used in an acute sense. They actually last only 4 to 6 hours. You should consider using them, but they're generally reserved in patients who are about to go to the surgery, or there's a plan for surgery. I generally don't think so that these patients whom we are trying to do just medical only therapy, I've used them for 4 to 6 hours. But again, keeping in mind that at that point in time, either you do surgery or not. So this is a very fine line that you go. And the PCO2 between 30 and 34 is very important, because we have seen that below 32, the patient starts to get decreased oxygenation into the brain that can actually worsen the stroke as well. So make sure that you do your PCO2 levels don't go below 30. I generally do not go less than 32, and with these continuous CO2 monitors on the ventilators now, we can technically monitor them continuously. So that's what I use in these kind of patients. Hypothermia doesn't benefit, barbiturate does not benefit. So when you have that increased ICP, and we're looking at the phase 1, 2 and 3 and 4 when you're treating ICPs, those are different places that we are using the ICP monitors. But in stroke situations, either you're doing hyperosmolar therapy, and if it doesn't work, you're going for surgery and take off the skull at the end of the day. These going into hypothermia protocol and going into barbiturate does not really work, and at that point you're actually increasing high risk of DVT, high risk of further decreased oxygenation to the brain, high risk of PE, and high risk of pneumonia. So generally the risk and benefit is very clear here, that there is no benefit, and there's reasonable amount of evidence in that regard. Corticosteroids should not be administered. They are very harmful, period, in all strokes, including brain swelling. This is not vasogenic edema, as you see in tumor patients. This is cytotoxic edema. And cytotoxic edema, you do hyperosmolar therapy. Vasogenic edema, you do corticosteroid therapy. Those are two different kinds of brain swelling, and therefore it is important to understand that steroids do not work in this kind of brain swelling. What is the optimal trigger for neurosurgical intervention? There's none. We don't know. To be honest with you, I have seen patients who have a lot of space in the brain. I would think, oh man, this is never going to go to surgery. She's 80 years old. But I was wrong. Of course, the patient didn't go for surgery, but at the end of the day, what I'm saying is that the swelling was pretty immense. And then there are patients who are younger and ended up not going to surgery and did well with medical management therapy. Generally speaking, you can, after doing so many things, have a sense of what to expect, but at the end of the day, there's really no good reason. In my opinion, if the patient is young, they're definitely going to go for neurosurgical intervention to remove the scalp and the skull. Do it sooner than later. As a matter of fact, my preference has been within 48 hours. If the patient is going to go to that area, and we know that she's young, and we know that he or she's young, we know that we're going to go ahead and do neurosurgical intervention, then sooner the better. But in patients who are, and that's actually number 2 point on that regard, saying that if the patient is less than 60 years old, within the first 48 hours, you should consider. And then if the patients are more than 60 years old, and again, this is all about how much space in the brain is expected and how much area there is to swell for the brain, you can make that expectation. So age of 60 is kind of a cutoff. Again, there's a big lecture on how to select patients for hemicranie. That is something we can't go into this particular series, and if you're interested, feel free to put a comment down in the comment box, and I will consider adding it to my next lecture series. Cerebellar infarctions are a little different. The problem with the cerebellar infarctions are clearly that the posterior fossa has a lot less space. And there are 2 interventions that can be done. Number 1 is basically removing the suboccipital craniectomy, or you can actually place an AVD from the top if the fourth ventricle is collapsed enough that it's causing an obstructive hydrocephalus. And those 2 can be considered in alone or in conjunction. Now let me explain to you a little bit why. Concurrently, ventriculostomy, when it's done after the suboccipital, is to make sure that the patient actually does not develop a lot of swelling around it, and then that can eventually cause a patient to have decreased recovery, tissue, recovery, and they end up having bruises and everything on this side because there's internal pressure, and that actually puts the patient on the pressure on the back, and those patients end up having skin breakdown significant, and then we are fighting an infection. So ventriculostomy, then the problem is if you're already doing suboccipital cranie, why to put the EVD? The EVD can actually cause upward herniation. So if you are putting an EVD, you're very worried about the upward herniation. So you have to be very careful that you're not causing upward herniation on these patients. So again, this could be done more, just suboccipital cranie plus ventriculostomy, and in very, very, very rare cases, what I've done is just the EVD, and those patients do not have a lot of swelling, but actually the swelling is in an area, especially in the SCA compartment, when you see that ends up causing a little bit of compression of the fourth ventricle, causing obstructive hydrocephalus. In those cases, we have just done EVD. But generally speaking, the suboccipital cranie plus minus ventriculostomy is the way to go. And believe it or not, those patients do a fantastic as compared to, because clearly their deficits are mainly ataxia, which actually improves over time. So those are the patients that even at a slightly higher age, I am actually very aggressive in considering them for sending for neurosurgical intervention. Seizures can happen in any way. For example, any bruise on any part of the brain can cause you to have seizures. Post-stroke is the most common cause of adult onset epilepsy. Treat as if you're having any other seizure. There's nothing exciting about it. However, there is no recommendation, and I repeat, there is zero recommendation of using prophylactically on any of the seizure patients. You actually have to have a clinical seizure to start an anti-seizure medication. As a matter of fact, there are anti-seizure medications that worsen the outcome, because what all of them do, sodium channel blockers or otherwise, decreases the firing capacity that actually can hurt the patient. So in my opinion, it's just not no benefit. It's actually kind of harmful if you use it prophylactically. However, of course, if the patient has a clinical seizure, go ahead and do that. Again, I'm very grateful for your time. Thanks for your time. Please like, subscribe, and share. Follow me on LinkedIn and Twitter.